Hi everybody, welcome to IPC Journal Club hosted by IPC Partners. Today is our 12th Journal Club, I think that's right. And it's a pleasure to have John on today to talk about antimicrobial services, time to rethink surface disinfection. This is a paper published in Antimicrobial Resistance and Infection Control. Just before I pass over to John, we'll do our normal housekeeping, which just explains a little bit about Journal Club if you're the first time attendee. But hopefully we've got some people who are coming back for repeat appearances. So IPC Journal Club hosted by IPC Partners, the idea is that between John and I, or a guest, as we have a lot of guests recently, we'll talk about a topical infection prevention control published paper. Really though, we want the slides and the analysis of the paper that John and I do to be there to generate discussion. So really, John and I only want to talk for 10-15 minutes, and then we want to hand over to you guys via the question and answer to answer questions, whether or not about the paper, the concept that's being discussed within the paper, implications for use in a clinical setting, implications for research, lots of different things that you can ask. And please, there are no silly questions, so please don't be afraid to use the Q&A. We're hoping to build a bit of a network as well. And like John and I said earlier, we've done this now for, I think this is the 12th time. So every Wednesday we're keeping this slot. We've got a really good panel over the next couple of months. We've got a really good amount of different guest speakers talking about lots of different topics. So we'll share that with you at the end. And ultimately, we want it to have a bit of fun as well, and generate some critical thinking. So the final thing, just before I pass over to John, is that all these sessions are recorded. We make them available on our IPC Partners YouTube channel, and I'll put that in the link for the chat for anybody who wants to go back and see any previous recordings. But without further ado, I'll hand over to John, and John can talk about this paper around antimicrobial services, and I'll see you back for the Q&A. Final reminder, the Q&A is at the top of your screens next to the chat button. And yeah, thanks, John.
All right, thanks, Phil. Hey, Phil, are you having fun?
When I take myself off mute, always.
It is quite fun. I've really enjoyed it. It's been a good thing. I'm starting to look forward to these.
I agree. Yeah. Thanks, John.
And it really is true that the best part of these is not so much the paper, not so much the reading it. It's about the questions, to see what people think, what kind of discussion it's generating. That's always the best part. Okay, so today we are talking about antimicrobial surfaces. I've just come up with a new description, by the way, of putting your slides into presenter mode, because I couldn't find the word, so I talked about big mode. So the slides are in big mode, and we are ready to go to talk antimicrobial surfaces. Now, antimicrobial surfaces and the prospects of them being a useful tool to help us to prevent, to reduce the risks from surface contamination, really, is something that's very close to my heart. It's a body of evidence that I've been looking at really closely over the last, 10, 15 years, really. And I think there's huge potential for this to become, almost the next big thing in terms of our prevention, certainly from an environmental and surface hygiene point of view. And that's because we now have really good evidence that the contaminated environment contributes to transmission. There is now no doubt in my mind that it is a really big and underrated driver for the transmission of all sorts of key pathogens that we're most concerned about: MRSA, VRE, Acinetobacter, C. diff especially, CPE and other resistant gram-negative. The environment is a really important cofactor in transmission. We know this from the prior room occupancy studies, the fact that if you're admitted to a room occupied by one of these patients with one of these organisms, then you're at an increased risk of acquiring it. And furthermore, if we do a better job of cleaning and disinfection, we know that that increased risk reduces either to baseline or even further, suggesting unrecognized colonization is a big factor in contaminating the hospital environment. So we know we need to clean more and clean better somehow. However, there are some fundamental issues with the delivery of hospital cleaning and disinfection related to the fact that we're relying on a human being. Now, you might say, well, okay, what about automated room disinfection systems? And they're less reliant on a human being. That's true. But we still rely on a human being to actually remove the dirt from surfaces in order for these automated room disinfection systems to do their thing. And secondly, no matter how frequently we clean, we can never clean continuously. Has anybody seen the film Wall-E? It's about a little robot and sort of a dystopian end of the world kind of area where the world is full of rubbish, and this little cleaning robot follows the source of contamination around all the time, clean, 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 clean. And it can never happen. We can never do that in a hospital in a way that could keep our hospital surfaces as clean as we like them to and as disinfected. So antimicrobial surfaces have been evaluated. They've been shown to be safe and effective. In broad terms, have demonstrated a reduction in contamination, and this has translated to a reduction in transmission in other studies. But this approach offers the potential to, at least to a degree, complement both the inadequacy of routine cleaning and disinfection in terms of its reliance on human beings, but also to act continuously to address surface contamination. So it's a concept that's very complementary with enhanced routine cleaning and disinfection, and indeed with automated room disinfection. So that's why I'm so interested in this study and in this study area as well. So this was a good one, nice study, enjoyed reading it, and it's a nice clear read, so I hope people have had a chance to have a look at it. So they looked at the impact of implementing an environmental, an antimicrobial surface called Nomabac in an emergency department setting in Singapore. So Nomabac is a modified acrylate and silane type product. Now, I don't begin to understand the chemistry here. There'll be others on this call who are much more knowledgeable about the chemistry involved. But it does provide, at least reputedly, continual non-exhaustive, so it doesn't run out and it doesn't leach into whatever it's inactivating. So it shouldn't turn your clothes green or anything like that. This was a single center, double-blind placebo-controlled trial. So they did saline as the placebo control, and it was an busy ED of a big hospital in Singapore. They selected the right-hand rail of the patient transport stretcher as the most frequently touched surface for the longest in the ED. We'll look at some data from that in a minute. And then they included all 96 patient transport stretchers in the study, which were randomized 1-to-1 to placebo or the intervention. The stretchers were then sampled immediately after routine cleaning and before application as a baseline, and then immediately after patient use and before cleaning, at 24 hours, 7 days, and 180 days after application. So they were looking for kind of a worst case challenge for this antimicrobial surface coating when they were sampling post-application. I think this is almost my favorite part of the study. They did a nice little pilot evaluation, just almost a time in motion type approach, where they observed touch frequency and duration in their ED over 2 hours. And what they found is that actually by some margin, this patient stretcher was the most frequently touched item. A couple of surprises here. If we look at the doctor's telephone, very rarely used. And some of the other items that you might expect to be the most frequently touched were not. So that's why they chose the patient stretcher as the surface to inoculate in this study. So what did they find? They found that the median total aerobic count was not significantly different at baseline. So that was good and not a surprise. Approaching a third of the stretchers exceeded what is a nominal kind of hygiene standard of 2.5 CFU per centimeter squared, despite routine cleaning at baseline. So quite a lot of what you might describe as, and have been described elsewhere as, hygiene fails at baseline, which is not unsurprising, not atypical. The median total aerobic counts were significantly lower on the coated surfaces at the 24-hour sampling point, with around 0.61 versus 1 CFU per centimeter squared, but they were not significantly different at the 7-day and 180-day sampling point. Similarly, the median count of gram-negative bacteria was significantly lower on the coated rails, but not at day 7 or day 180. That was partially due to a very low level of contamination. And for gram-positive bacteria, the median counts were lower, but not significantly so. Overall, the proportion of stretchers exceeding the kind of hygiene fail standard of 2.5 CFU per centimeter squared was not significantly different at any stage of the study. But as we'll look at when we look into the data in a bit more detail, there were some really compelling trends on this point. Interestingly, and I think what shockingly, really, certainly from a UK NHS perspective, MRSA was identified on 20% of the bed rails at baseline. And remember, this was after routine cleaning, when these things were ready for the next patient, but there were no significant differences in contamination levels at the various sampling points. The study did show that MRSA was detected on 35% of the pre-routine cleaning post-patient use non-intervention stretcher rails, although I struggled to tease out, if I'm honest, from the study, the comparison with the intervention rails here. So I think it was to do with very low levels of MRSA that were detected overall, which made the comparison difficult. So here we are. This is those data that I've summarized in table form. And you can see on the top line there the significant reduction in the total aerobic count, or the significant difference rather in the total aerobic count at the 24-hour time point. And you can see it was reduced at the 7-day time point as well, but not significantly so. Now, I mentioned earlier, this is the data looking at the number of the stretchers with the contamination exceeding the 2.5 CFU per centimetre squared. So no significant findings here, but actually if you look at the numbers and the percentages, the proportion of surfaces that were dirty were reduced in the intervention arm, but not significantly so. So on to then the strengths and limitations of the studies. I think the main strength actually is the study design. This was a really nicely configured study. You don't see too many double-blind, placebo-controlled, randomized controlled trials. It was very ambitious, and it was undertaken in an an ED setting in Singapore. Now, those of you who worked in an ED or walked through an ED, it is not an easy environment to manage. There's a lot going on. We're asking a lot of our staff, and we're asking a lot of our equipment in these areas. They get thrown around, beaten up, perhaps more so than elsewhere in the hospital. So it's a very tough environment for an antimicrobial surface coating to be trialed. One limitation is probably the study was a bit underpowered. I think by the author's own admission, they probably didn't have sufficient sample size to detect a significant difference, given the actual differences in colony count and proportions that they observed in the study. So in hindsight, perhaps a formal sample size calculation might have helped them to create a sample size, or maybe even the study duration that would have resulted in significant findings either way. There was a lack of microbial coverage in their methodology, so they didn't include C. diff, they didn't include a wider range of resistant gram-negative bacteria that we'd like to see, the CPEs, Acinetobacters that are resistant to certain antibiotics, no VRE as well. So they could have certainly covered more ground in terms of the microbial ecosystem that they were monitoring. Perhaps the most fundamental limitation of the study really is that there was no clinical outcomes. So there was no assessment of whether implementing this antimicrobial surface coating resulted in a reduction in the acquisition of colonization or infection with significant organisms. So what does this make us think about? Well, one thought is around MRSA prevalence. 20–30% of rails contaminated at various parts of the study is high. I certainly wouldn't expect to see that in the UK today, although I would have expected to see it 20 years ago. MRSA prevalence in Singapore is high generally. I read a study suggesting that some 30-odd% of Staph aureus from a selection of infections was methicillin resistant, which is higher than we'd see in the UK and in most parts of Europe nowadays, but not dissimilar to how it used to be. A big question, I mean, the million-dollar question really, is which antimicrobial surface technology should we be evaluating? There's a massive range of options that we can take to make an antimicrobial surface in some way, either by improved cleanability, reducing the ability for organisms to deposit and survive on the surface, or direct antimicrobial activity. One commonly quoted potential issue or actual issue with antimicrobial surfaces is durability. And this study highlighted that in that only 3 of the intervention rails, that's 3 of what the 40-odd that were actually coated, had a visibly intact coating after even 7 days. Let me just flick forward to a picture here. So this is a photo of the bed rail. It's slightly difficult to see, but you can see on the left-hand side of that picture, there's a bed rail with a label stuck onto it, and the right-hand rail is what happened when the label came off. We're coming up to Christmas, and you might be doing a Christmas quiz where you have one of those pictures that are really close up and you have to look at really hard to see what it's representing. That picture is a bit like this. We're looking top down on the bed rails here. And you can see that the coating next to the white arrow, you can see it's intact at the top and it's not intact in the bottom, or at the bottom rather. And related to this, really, there's big questions around antimicrobial surfaces generally, around the frequency and the method of application. So how often do we need to reapply, if ever? Is it manufactured into the item at source? And how do we reapply? Is it sprayed on, painted on, vaporized on, at various different options? Questions around safety and acceptability. How do we assure ourselves that antimicrobial surfaces are safe and acceptable to patients and staff? The coating used in this study was FDA approved. This won't be true of all coatings in terms of their regulation. So what steps do we need to go through, even prior to evaluation, to make sure that this surface is going to be safe and not have unintended consequences, and equally will be accepted by staff? There's certainly some feedback from looking at the hard metallic coatings, almost copperizing a surface, which has been done and shown to be effective to a large degree, actually. But then some of the patient feedback is understandably, look, I don't really want to sit on a copper toilet seat. It's a bit cold. So, and yeah, these things, these daily realities for patients and staff are important when it comes to whether an intervention will be effective and adopted. How do we manage the relationship with routine hospital cleaning and disinfection? There's potential tension. Will the routine cleaning and disinfection process itself damage the antimicrobial surface? Or will introducing an antimicrobial surface that's always active actually reduce the perceived need for cleaning and disinfection? And might it result in an unintended reduction in the standards of hospital cleaning and disinfection? And then this question is a little more esoteric. How good is good enough? We know that antimicrobial surfaces are unlikely to sterilize the environment. We're not going to have one that when they're not going to act like, you know, those sort of blue light fly zappers that you might see in a baker's when the fly lands on it, the fly is vaporized. I don't think we're ever going to have an antimicrobial surface that does that to microbial contamination in a hospital setting, because that would probably not be safe for patients or staff to be touching and to be interacting with regularly. So I think we'll probably have to accept that they will reduce the level of contamination, but they won't keep it, you know, something close to sterile. So then the question becomes, well, how far do you need to go? What's the level of reduction that you need in order to translate into a significant reduction in healthcare associated infection risk? So I'm not planning to go through this table line by line because it's massive and it's detailed, but there's a reference there to the blog post that I did with this some years ago. I'll put it in the chat when I finish talking. And I just want to use it as an illustration, really, of the huge variety of options we have when we say, well, let's go for an antimicrobial surface. We could go for a metal-based one, a chemical-based one, or a physical alteration of the surface properties, or perhaps a combination of those two might be the ideal. So what does this mean for IPC then? Well, I think the lack of patient outcomes really does hamper our ability to get to the real root meaning of this study for us. There are other studies, though, that do show that improvements in patient outcomes are linked to the introduction of antimicrobial surfaces of various kinds. So what we really need, I think, is some comparative effectiveness studies to help us understand which antimicrobial surface to go for in various settings, and also, of course, the healthcare economics to help us understand whether the pounds and the pence or the dollars and the euros add up when we're thinking about introducing an antimicrobial surface. So Phil, I'm going to hand over to you and let's see what questions we've had coming in.
Thanks, John. We had a special guest for all of that. This is Mango. She was listening intently on my lap. Thanks, John. Did a really good job, as always, of explaining the paper. I should have said in the introduction, I was involved in a 3-year postdoc, not myself, but I supervised one on antimicrobial surfaces, and I was just blown away by the complexity of how you choose a candidate and then how you integrate it into material. And like you said, I don't have the first clue about the chemistry, but it is mind-boggling. So the fact that they've been able to do this in quite a high-powered study is quite encouraging. We have got a couple of questions, John, and I'll go to them in a second. But if I can start, did they talk about how the study was actually blinded, or were they just relying on the fact that you couldn't see the difference with the naked eye between a surface that had been coated and one that had been and hadn't been?
So I promise you, I read every word of the study. I really did. And I read how they blinded it. I can't remember exactly what they said. I think it was certainly blinded application. So those applying the surface didn't know. And then they thought that you couldn't tell the difference between them once coated.
Yeah, that's what I thought. I mean, you could see on that photo you showed where it had started to peel off that it was visible, but I wonder if you wouldn't have been able to see it that well if it hadn't been kind of interfered with. The other question I had was, do you think, I mean, this is slightly outside of the whole point of the topic around antimicrobial surfaces, but that data you showed about the frequency of different things being touched within the ward, do you think there was any maybe Hawthorne effect from where they were observing those touches, whether or not behaviours might have been a little bit different?
Yeah, I think that's really quite possible, isn't it? That if for example they'd said to the whole team that we're doing this study, we're going to coat this antimicrobial surface coating onto what we found to be the most dirty surface in the whole ED, based on how many people touched it, then you might see how that might mean, well, people are a little bit shy of touching it, so that might have influenced the results. They didn't let us know exactly how they communicated this study to the wider ED team, at least in the main text of the study, so we don't really know, but it's certainly a possibility for maybe a little bit of confounding or bias in the study.
Okay, thanks, John. So just a reminder to everybody, the Q&A is there at the top of your screen. Sally asks, this is quite a long one, but there is a good question at the end of it. Increasingly quantitative microbial risk assessment is being used to convert the sort of data shown here into quantitative assessment of the reduction in clinical infection rates. How would you feel about this? Is this the way forward for assessing efficacy of environmental hygiene interventions where RCTs are difficult and have limitations of their own? Do you think clinicians would be prepared to accept such data?
So I think two parts to that then is A, is it a good idea? And B, would it be accepted by people working in clinical roles in frontline healthcare services? So is it a good idea? Undoubtedly, it's a great idea. It's a really good idea. I think it's very similar to the idea of mathematical modeling in terms of disease transmission. We're using all the available evidence, we're putting it into a big model using parameters that make sense and have evidence behind them to see what impact that has on transmission in that artificial environment. And it's a similar concept. You're taking the various aspects of the process, breaking it down and looking at applying relative risk factors to each part of the process and coming up with an overall risk balance, really. I've tried to do something along these lines related to the environment before, because there is some semi-quantitative data that looks at the level of contamination of a surface, or at least proxy measures of the level of contamination and how that translates to risk involvement transmission. So, for example, looking at the prior room occupancy data, when this was a study looking at VRE, and they found that when the immediate prior room occupant had VRE, that was the highest risk of VRE for the incoming occupant. If they'd had VRE in the last 2 weeks, then it was an intermediate risk. And if they'd had VRE in the last year, it was the lowest risk. So you can see how there was a sort of at least a semi-quantitative relationship there between the level of surface contamination and the risk of transmission. Quite a few studies have looked at how you can semi-quantitatively measure the level of contamination and correlate that with the degree of cross-transmission. And some of the copper intervention studies, from memory, have done that to say we can see this copper surface of reduced transmission, and the degree to which it reduced transmission was correlated to the degree of microbial reduction there was. To the second part of the question, though, would be accepted. It's difficult to say. I think ultimately no, even though it probably should be. I think there still will be a call for the big gold standard cluster randomized intervention trial of an antimicrobial surface technology to really nail the actual nail and scale, I suppose, the reductions of contamination that you would or would not see.
Thanks, John. Really helpfully, Shireen, hi Shireen, in the chat has listed what the different ingredients in that coating were. I'm not going to attempt to pronounce them, but apparently a combination of 3 different biocides: fungicide, bactericide, algicide, fungostatic, bacteriostatic, respectively. Apparently one of the ingredients is banned in the EU. So interestingly, how you said it was FDA approved?
Yeah.
Yeah, but not obviously not in the EU. Just carrying on from what Sally had said there about, the way that we assess hygiene, and whenever I read studies like this one, my brain always goes to the idea of culture versus culture independent. So, using more molecular methods to assess surface contamination. And I just wonder, do you think that we should, given, the advent in sequencing and how much easier and cheaper it is now to go and do metagenomics, for example, on a sample taken from the environment, do you think that perhaps studies should be going more along the molecular way as opposed to trying to culture microorganisms, when we know there's so many challenges to try and culture organisms in the lab?
Yeah, I think there's a lot of value in that. Certainly as part of sort of outbreak investigation, where you really want to make sure you've turned over every stone to look for environmental reservoirs. I think molecular methods make sense to look at contamination in the environment. I guess the issue you often have, though, is how does the presence of the small bit of intact DNA that is required, or RNA, to detect the organism on the surface, how does that relate to the actual viability of the organism? I think with something like quantitative PCR, there's some pretty good data that actually you can draw quite a good correlation between the CT value and work that back to probable viability of the organism on the surface. But there is uncertainty there. Slightly differently, metagenomics is a really, really nice approach, which allows you to understand more about the totality of the microbial ecosystem on the surface and how an intervention changes that. But it is a different way of thinking, and a different way of understanding and interpreting what it means. So if for example, we measured the impact of, say, a new disinfectant on a surface or an antimicrobial surface in it with a metagenomic method, I think it would be almost applied basic research to understand how to interpret that change in signal.
Makes sense. Maybe that's for the future. Comment here from Kerry, not a question, but a good one. I'd argue that antimicrobial coatings are the wrong approach. Coatings can make a mess of surfaces when they break down, risk of build-up, hard to formulate without making it sticky. I'd advocate that we strive for residual efficacy formulations that are active between cleaning events. In this way, we create a very effective formulation without the issues with coatings, and it's much less expensive. So that's around this principle of having residual activity in a disinfectant, which is another way of looking at it.
Yeah, I mean, you might counter argue that actually having a disinfectant with residual activity is a way of applying an antimicrobial surface coating. So I think I'd probably see that as part of the same bracket, and that your daily routine cleaning and disinfection is your mode of application, and you're topping up the level daily. And there is some evidence that quaternary ammonium compounds, for example, do have some residual activity between cleaning episodes. It's not fantastically high, but it is there. And I think there's other approaches thinking about maybe sort of nanoparticles, or maybe metallic nanoparticles, where you could look at enhancing that level of inactivation that you get.
Yeah, agreed. I'm going to be controversial, John, and ask your opinion on this. Do you think that what we require from new technologies like antimicrobial surfaces, for example, are almost making it really, really difficult to implement change? Because I just think about the way that we clean and disinfect the environment at the moment, and we rely on a lot of traditional approaches that we've used for decades, chlorine, for example. We didn't kind of look at the efficacy of chlorine in a real world setting and do an RCT before we implemented it. We did the lab test and we showed that it was good in clean conditions against these organisms, etc., etc. But we didn't go and do an RCT and say, oh yeah, chlorine is much better than just cleaning with detergent, for example. So do you
Yeah.
think, the bar is set too high, or do you think that things have just evolved and that's where we are now? And, I'm not saying we shouldn't strive for data like RCTs, but do you think actually that sometimes there might be a bar? If you think about a small company as well, trying to innovate in this space, do you think
Yeah.
sometimes the bar might be set a little bit too high?
Yeah, I think it's a good question. If you look at something like hand hygiene as well, when you really boil it down to the randomized controlled trial grade and quality of evidence, it's not really there. I don't think it's asking too much to say, let's have a really nicely designed randomized controlled trial with a patient level outcome to evaluate the potential for an antimicrobial surface coating to reduce transmission. I think increasingly as the really, let's call it, a requirement for that level of evidence to affect meaningful change within IPC has increased, people have shown that it's possible. We've seen RCTs, many of them for various skin cleansing and antisepsis options. We've seen RCTs for the automated room disinfection systems. We've seen RCTs for new surface disinfectants. So I don't think it's an unreasonable expectation. But what it does require is a really carefully thought out and cannily funded research program. I don't think it needs to be massive budget actually, because it wouldn't need to be a huge number of patients over many, many hospitals. And I think one of the advantages with an antimicrobial surface coating is that you actually can evaluate it quite unobtrusively. So once you've got everything lined up and the study configured properly, it's a background intervention. It doesn't require massive further babysitting to make sure that people are adhering to the intervention in the same way that some interventions in IPC do require. I guess perhaps the counter argument is, well, you can't go straight to an RCT with patient level outcomes. If using today's study as an example, if they'd gone straight to an RCT with patient level outcomes, they'd be kicking themselves, because actually the learning from this study hopefully would go back to the manufacturer of the antimicrobial surface, and they'd say, look, after 7 days, 97% of your surfaces weren't there anymore. So you need to think about the way that you're applying it in the bonding to your surface. So if they'd gone in straight in, put however much money into a randomized trial with patient outcomes, and it had shown it didn't work. Well, of course it didn't work, because 97% of your antimicrobial surfaces were degraded by day 7. Then you'd be kicking yourself. So I think, which is why I think it needs to be a canny research program that has enough well configured experiments at the front end to make sure that when you get to your patient level intervention, you've got a good chance of actually evaluating outcome.
Yeah, definitely. And I think, this study actually shows the amount of developmental work that needs to go into these products if they're going to actually make a difference in a real world setting. And like you described at the beginning, A&Es are busy, quite hostile environments. There's lots of damage to equipment. There's lots of people moving through them. So these coatings need to really be able to have good durability, don't they? I guess final thought, what do you think it would take for an antimicrobial surface to be widely adopted in the NHS in England, for example? Is it data which is showing a patient or clinical outcome?
I think short answer, yes. I think if there was a nicely designed randomized control trial, again, I don't think it needs to be a massive piece. Then that would be convincing, I think.
Great. Thanks, John. Any further comments, John, before I just... Oh, and I've gone too far. Bear with me.
Yeah, I was going to just ask you a question, Phil, because looking at that table with the whole slide full of potential options for antimicrobial surface coatings, and that's just scratching the surface, excuse the pun, of the many, many options that there really are, and even the number of categories that there are. If you thought, based on this or something you thought before, this is really good, I'm interested in doing some work on this, where would you start in terms of looking at which antimicrobial surface coating technology area to look into?
Gosh, that is a really good question. Um, I think I'd want to do my own systematic review of what's out there and see if I could find some trends and see if there is a candidate which has got more evidence than others in terms of efficacy. But I think the main place I would be looking to begin with would be around safety. So to ensure that these compounds, that they haven't got any side effects or they're not going to cause issues with skin or when they're coming into contact with patients or being touched by members of staff. So I think I'd probably start somewhere between safety and efficacy. And I think it, like you said, it does make for a really nice, well designed, cannily funded study. And I think this paper actually does really, really well to do an RCT in such a busy environment like A&E. But I guess to answer your question, I think I'd be wanting to kind of delve into the literature myself. I'm an evidence man, and see where the strongest potential was around efficacy and safety, and probably with a blend of durability in there as well. So I think there would be a lot of work to do with commercial partners to kind of ensure about to understand, sorry, the developmental work that had gone into it. What about you?
I was asking the question, not answering it. Because it is a hard question, isn't it? I don't really know where to start. And as I said, I've been following this space quite closely over the past 15 years. I think I'd probably want to be ambitious and aim for the kind of nirvana antimicrobial surface coating that
Sure.
reduced deposition, improved cleanability, and had a direct antimicrobial effect. Um, I'm not sure there is an obvious one of those, but I feel like it's within our technological grasp. Now we are in a very much a kind of nanotechnology era. And I suppose there's other boxes we need to tick around cost and feasibility and safety. But just in principle, those kind of three key benefits, that's the sort of things I'd be looking to combine, I think.
I'm going to ask you one more question. When you talk about cleanability, do you mean how does that make the surface easier to clean?
Yeah, exactly.
Okay,
So you can if you change the kind of hydrophobicity of a surface,
sure.
you can actually make it easier to clean. If you're trying to clean a block of wood versus a nice clean plastic surface, it's a very different cleaning experience. For example, that kind of concept.
Okay. Yeah, perfectly makes sense. I think it's not in the realm of antimicrobial surfaces, but design of shared patient equipment is really important, isn't it? To make
Yeah.
sure that it is cleanable and it's smooth and it doesn't have nooks and crannies where bugs can hide, etc. Great. All right. Thanks a lot, John. Great analysis as always. I'm just going to finish. We've got a really, really exciting schedule over the next couple of months. We've actually got speakers all the way into February next year. So we're really pleased about that. So our next one is on the 4th of December, and we're delighted to welcome Professor Martin Keenan, with John and I facilitating the Q&A. John and I then have got one around automated hand hygiene, which will be our first delve into hand hygiene from IPC Partners Journal Club. Then again, another really high profile guest, Dr. Alexander Sunderman from the US, going to be talking about genomic surveillance for IPC. And then the final bit of actually really big news for IPC Partners is that we've partnered with the Healthcare Infection Society, HIS, and we'll be doing a webinar around water-free care and healthcare water systems on the 22nd of January, which will be chaired by Shannon Ali. And again, thank you everybody for listening wherever you are in the world. Please have a look at the recordings on YouTube. If you have any questions or you're interested in being a guest, you can contact us on that email address, and there's a website there below, and we're also on X and LinkedIn as well. Thanks again, John, and we'll see you all in 2 weeks' time.